Associate Professor of Pediatrics at Stanford University School of Medicine. He's the Chief Medical Officer for the California Perinatal Quality Collaborative. In that role, he helps to administer the quality improvement and research programs of this network, consisting of 138 neonatal intensive care units, and he's the co-chair of the Neonatal Resuscitation Program Steering Committee at the American Academy of Pediatrics. So Dr. Lee will talk to us about his experiences from the California Perinatal Quality Collaborative. Dr. Lee, the floor is yours.
Thank you, Dr. Spani, and appreciate the opportunity to be part of this meeting with the TCHMB and to represent the California PQC. It's great to be part of a state collaborative to learn from within our state, but I think it's equally as meaningful and beneficial to learn from each other as state perinatal quality collaborative. So thank you. Go to the next slide. So yeah, in these next 20 minutes, I'll give a brief overview of our California Quality Care Collaborative, describe some of the collaborative QI work on the topic of temperature and preterm infants, go over some trends and the variation in our state, talk about a high performance center, and then end with a mention of our toolkit and health equity dashboard. Next slide. So CPQCC started in 1997 and over the past 20 plus years has come to include 100, it's now 140 of the 150 NICUs in California. We collect detailed data on 17,000 NICU admissions annually, and our members have about 50,000 NICU admissions overall annually. Next slide. From the start of the collaborative, perhaps one of the main principles that has driven the agenda of CPQCC is data-driven quality improvement. And this is an example of a screenshot of one of the quality reports that a hospital could see to go over their NICU numbers and quality measures. Next slide. And the QI activities of CPQCC are driven by volunteer committees under our perinatal quality improvement panel. There are 4 main committees, 3 of them are shown here. The data committee reviews the data for opportunities for improvement and helping members to do that for their individual NICUs. The research committee evaluates QI activities and how to perform quality improvement better. And then the education committee plans our annual state meeting and helps to publish toolkits for quality improvement. Next slide. So our education committee has planned a great meeting on March 5th that we are calling Improvement Palooza, Advancing Anti-Racism in the NICU through Teamwork and Family-Centeredness. And I've really certainly appreciated this meeting yesterday and earlier today on these topics, very inspiring. And I hope that we'll have a similar experience with our state work, and also invite you to attend if you're interested on March 5th, which will be virtual. In 2022, we hope to have an in-person meeting as our state collaborative and invite anyone as well to attend that, which is annually in Coronado Island off of San Diego. So a great place to visit as well. Next slide. So our 4th committee, the QI Infrastructure Committee, plans and implements what might be considered our larger scale collaborative QI projects. And these have been based on the IHI model for improvement. Usually they last for 1 to 2 years and involve around 20 to 25 NICUs typically. And you can see our history there with these large scale collaboratives. And in 2011 to 2012 is when we had our delivery room management collaborative. Next slide. There had been growing interest in that topic of delivery room management starting around 2007 when this toolkit was published. And it wasn't just about temperature, but encompassed many aspects of improving quality in the delivery room. There was a chapter that concerned maintaining normal infant temperature. And during 2007, 2008, we had various events to disseminate the toolkit, including several in-person regional meetings and speakers who spoke to each of various topics in delivery room management. and then several webinars where the toolkit was disseminated. Next slide. Now, when we think about temperature, maintaining it, it's a complex topic. I appreciate Dr. Laptuk did a great job of outlining the many factors involved. Just to note again that this is an association, and ultimately a baby having a low temperature could be related to things that happen sort of as risks before, but ultimately part of that also could be if a baby needs resuscitation, then it will be more difficult to pay attention to thermal management. So in some ways, improving the resuscitation overall, along with the amount of intervention needed, will help to also keep a normal temperature. So it's kind of interrelated, perhaps. Next slide. So we conducted a delivery room management collaborative from 2011 to 2012, and the goal was overall improvement in that setting, but there were three main focuses. The first was actually to avoid hypothermia for preterm infants. The second was to establish lung volume in the least invasive manner, ultimately trying to limit intubation if possible. And then third, supporting teamwork with checklists, briefings, and debriefings, which would be important for any delivery resuscitation. Next slide. We did an analysis after the fact to see how things went and considered three groups. There were 20 NICUs that participated for the full duration of this project, what we call our collaborative QI group. And these centers met monthly, had frequent report outs, as well as access to an expert panel. And they had several in-person meetings as well to learn from each other. We had 31 NICUs that we called NICU QI that were actively working locally at their hospitals on this effort, using the toolkit and various tools that we had allowed them to have access to. But they were not meeting with other NICUs during this course of this project. And then there were 44 hospitals that were the non-participants that were in neither group. Next slide. And so these are the results. What we saw here in the left was that all NICUs on average improved in reducing hypothermia. So it's percent hypothermia. The collaborative NICUs, though, had a significantly larger decline, so therefore an improvement in terms of reducing hypothermia. Of note, if you look on the right, though, there was also an increase in hyperthermia. So temperature, that was sort of that was our balancing measure. So I think the lessons here were that collaborative quality improvement perhaps works better than doing it on your own. And that also it's important when we're thinking about maintaining good thermal environment that we have to watch out to not go too far to overshoot. Next slide. This is one of our CPQC reports, which is showing normothermia, or temperature 36.5 to 37.5, and showing over time the experience actually of one hospital, which is the hospital where I work at Stanford. And our NICU did participate in that collaborative, and perhaps you can maybe see here that between 2010 and 2012, that there was an improvement in percent normothermia. And then it kind of remained stable, but not improving very much after that. And then locally, we noticed that we weren't doing as well and had some increased efforts. I think attributed that perhaps to that more recent improvement in the past few years. Next slide. This is a figure, same figure, but now with that blue line overlay, shows the average across all California NICUs. And I imagine this has been, generally the case across all of our NICUs across the country, as this has been more of a focus in terms of delivery room care. But you can certainly see here there's been a steady improvement. And I do think that part of this for our state has been a steady attention to it over this past 10 years. Next slide. This is another sort of way that we look at our data in CPQC, is just showing each of these dots representing one NICU, and this shows the variation across the state, where although the average has improved, as I've just shown you, there's still a lot of variation. So we can see here that there are some centers that are doing really well and some that could improve still. This is a 3-year average across 2017 to 2019. And seeing this type of figure for us locally at Stanford was part of the impetus to work more on this issue. So before going to the next slide, just note here that the average for California over the past 3 years or so was just above 75%, and the low performers, so to speak, are around 50% or so. And then if we go to the next slide, you can see here, this is hospitals in 2006. And you can see here that the average was actually below 50%. There are many NICUs below 50%, and there are even quite a few centers that had less than 25% with normothermia. So it is neat to see that we have made good progress in this area. Next slide. This is a table for 2019 for extremely low birth weight infants or less than 1,000 grams at birth, that there were about 3% or so that had moderate to severe hypothermia, and ultimately 76.3% were normothermic. So perhaps some work to do still, but overall large improvement, from previous years. But you can also see here that the mortality rates for those very cold babies is quite high. Next slide. This table similar for 1,000 to less than 1,500 grams, and there are fewer with moderate severe hypothermia, about 2%, and ultimately also less mortality, even if they are somewhat cold. So the focus perhaps may continue to be particularly on the smallest extremely low birth weight babies in regard to our efforts in this area. Next slide. I'll just give you an example of what we consider a high performance unit. And this one way I think we could learn is just seeing who is doing something well and seeing what they're doing. And this group has been working on this issue, I know, for quite a while. They published this report recently on their experience, and they implemented a thermoregulation bundle. And they've done sort of the usual things that are part of quality improvement in this area. But perhaps one thing they note, and I've talked to the folks there, and I think they really think this is an important part of it, is that they were able to have a dedicated delivery room, operating room, with a temperature 24 hours a day at 74 degrees. So, I think that they attribute at least a lot of their success to that aspect of their work. Next slide. And their results have been that out of, over the past, from 2014 to 2019, they had 91% normothermia amongst their 200 ELBW infants. And of the rest, 5 were mildly hypothermic, 13 were hyperthermic, but they had 0 infants less than 36 degrees. So, compared to other centers, they were doing very well in this regard. So I think we can learn from them. Next slide. It's been a great meeting thinking about how we can address racial ethnic disparities in care. And one thing that we have been able to do in our NICUs is to show and evaluate that there are disparities both within and across NICUs. And this is one figure that kind of shows that each of these dots representing, or bars representing a NICU, the degree of the length of that line shows the potential disparity that exists within that NICU. Next slide. And what we have seen for both Black and Hispanic infants is that they tend to have a higher rate of not being normothermic, I guess, and no hypothermia is how we sort of rate the quality measure. But it does tend to be the case that on average, white infants do better in that regard. Certainly, there's no biological reason for that to be the case. Next slide. And so this is an example of our health equity dashboard that we've implemented. And you can see here, this is showing on the right side, normothermia by race ethnicity. And, so better, higher is better. And you can see for us, if we look at this figure, we'll see that, there's really no reason why it should be. If we're improving quality overall, then it should be equitable. And we can see here it hasn't been. And then that draws attention to the fact that we need to look into, further why this might be the case, why non-Hispanic white infants are more likely to be normothermic than others. And so I think this important aspect of quality improvement with an equity lens, as was discussed earlier. And so I think it's one aspect of our work that we're trying to to improve on even further as we do quality improvement. How can we make sure that we do it in an equitable fashion so that all benefit? Next slide. So that's the end of my presentation. We do have a delivery management quality improvement toolkit that's available online at our website that is free for download and open to suggestions as well. It's been a little while since we've updated it. And we do have our meeting coming up. If you have questions or interest, please feel free to reach out. Thank you very much.